So in this session, I'm going to be focusing on a particular type of intervention known as contingency management, which is based on the principles of learning theory, which we covered in the previous learning theories of addiction session, in which there was a particular focus on operant and classical conditioning. So I'll start off by giving an introduction to what contingency management is, and then we'll look at some of the effectiveness data and evidence, and think about what are some of the barriers to the implementation of contingency management, because one of the interesting things about this is that despite being a very heavily evidence-based intervention, it's actually not that widely used. And then I'm going to finish just going through some recent research that I've done with colleagues evaluating a particular type of contingency management, something known as the capital card. So what is contingency management? Well, it's in simple terms, it's based on the principles of operant conditioning. So you'll recall from the previous session that operant conditioning is learning by doing. So it's reward-based learning where there's some form of reinforcement or punishment, but it's based in a clinical context. Contingency management is based on the application of positive or negative reinforcement to encourage behaviour change. And this is something that's actually been around for quite a long while, and contingency management has been used very widely across lots of applied behavioural analysis techniques, looking at in an education context in particular, and has been used since at least the 1960s with regards to the treatment of substance misuse. So it's not new, and so if you haven't heard of it and you work in the area, then that's in itself quite interesting. So contingency management can take a number of different forms, but usually, almost always, it involves some form of monetary reward or money-related reward. It can be voucher-based or token-based. It can involve cash changing hands. Very often, in the context of treatment centres and interventions, it will more often involve vouchers or tokens. It can also sometimes involve prize draws, and so rather than people being given cash or voucher or token-based rewards, they may be entered into a prize draw. And if you, again, reflecting back on the work around operant conditioning, this is something that we'd describe as a form of variable ratio reinforcement, where people know that they can win a reward, but it's not a certainty when exactly they'll get it. And interestingly, it's almost always tied to treatment conformity. So, for example, a service user may be given vouchers, tokens, or be given tickets to enter a prize draw as a result of providing a clear urine sample in the case of opiate users, or a clean carbon monoxide breath reading in the case of people who are aiming to cut back or quit smoking. In terms of the effectiveness of contingency management, I mean, it's pretty much one of the most widely researched treatments there is for substance misuse, having been around for a very long while. It's also in our National Institute of Clinical and Health Excellence and NICE guidelines. The clinical guidelines CG51 recommends that we look at the wide implementation across the UK, across the NHS, to treat drug misuse in adults. And there's a specific phrase here, this is a screenshot taken from the conclusion of this section of CG51, where they say that successful implementation of contingency management will have considerable benefits for people who misuse drugs, their families and wider societies. So the jury's not out on the effectiveness of contingency management. We are fairly clear that contingency management is a very effective way of improving treatment outcomes for people who misuse drugs. Beyond that, that's a particular recommendation from the NICE guidance, but looking at the Cochrane review database, Cochrane database of systematic reviews, which is considered a definitive resource for looking at the sum total of all of our knowledge in various different areas, we know that there are multiple Cochrane views which demonstrate a high degree of confidence in the effectiveness of contingency management. Taking Caitlin Notley's recent 2019 review, she and her colleagues concluded that there's clear and strong and reliable evidence that incentives can be used to promote and improve smoking cessation treatment outcomes, and in particular when they looked at subgroups of people that were involved in the trials, pregnant women in particular were clearly more likely to quit and to remain abstinent postpartum when given incentives or were involved in a contingency management type intervention. Interestingly, the size of the reward itself was not associated with the efficacy of contingency management. So the range of rewards in the studies that were included in this particular review range from $100 to $700, or their equivalent depending on the country that they were being used. And it has to be said that contingency management has been far more widely used in the United States than other countries, certainly in terms of a lot of the research that's available. So it's interesting that the size of the reward seems not to be associated with the efficacy of contingency management, and possibly the simple reward in and of itself, so long as it's something that is reasonably valuable, is more important than quite how large the reward is. Another Cochrane review, Minozzi et al., reviewed evidence for different psychosocial interventions that support people with psychostimulant misuse problems. And so in this particular review, it wasn't looking at contingency management as a treatment or an intervention in its own right, but rather looking at treatment as usual, various case management and clinical support interventions that are available for people with psychostimulant misuse problems. And what they concluded from this review was that the use of contingency management in addition to treatment as usual appeared to be the most promising adjunct to treatment as usual. So the idea there being that it's something that will enhance ordinary treatment by adding contingency management on top of treatment as usual, and they recommended in this review that there should be further analysis in this area. So why are there barriers to implementation? Well, despite being one of the most well-evidenced interventions, it's not widely used, and the sadly late Nancy Petrie, who did a lot of really good work in this area, summarised some of the reasons why people may be, and practitioners and policymakers may be not likely, or why they may be not likely to implement contingency management as part of a treatment service. And so some of that can be a lack of training and awareness. Now, contingency management is based upon the principles of applied behaviour analysis. That involves having a good understanding of things like operant conditioning and understanding how to ensure that you're matching rewards and behaviours appropriately. So a lack of training and awareness is one barrier, and an understandable one. But there is also an ideological barrier and a moralistic objection that sometimes comes up in relation to a discussion about contingency management, because given that very often contingency management is, as I said, more often than not used in relation to treatment conformity, there's a sense that people have, I think, that's been demonstrated from work in this area, that there's a concern that you're kind of paying people to do something that they should be doing anyway, and that some people just have an ideological or moralistic objection to that. There can also be, from in a more structural sense, a lack of understanding amongst, say, commissioners of treatment services, a lack of understanding of what contingency management is, and therefore a lack of demand on their part for it to be part of commissioned services, meaning that particularly in the UK context and the way that our services are currently commissioned, that organisations who are putting tenders in for services in different areas may not necessarily feel that they're going to be successful in securing services in an area or contracts if they include contingency management, if there's a lack of understanding on the part of commissioners who are holding the funding. And of course there is also a concern about cost. This sort of thing doesn't necessarily happen without any money, although we'll see an example of how this can be operated in a much more cost-effective manner just shortly. But the simple reality is that it almost always costs money to run contingency management interventions. Now, spend a pound to save a pound, the basic principle that prevention is better than cure. If we can get better treatment outcomes for people with substance misuse difficulties, in the long run that's going to save money. However, unfortunately, sometimes short-term cost implications can get in the way. Just in terms of how frequently contingency management is used, a study by McGovern et al. In 2004, this was in America, found that fewer than 10% of drug and alcohol practitioners were using contingency management as part of their routine care. So this was across a number of different services. So 1 in 10 were using contingency management, despite the fact that it's one of the most effective, and particularly if you're using it in addition to other forms of treatment, one of the most effective things that you can do to promote positive treatment outcomes. A further trial involved the provision of training, and so this was an implementation trial to find out if you go to a particular service, train everybody in a particular technique and see whether or not they use it. And so bearing in mind the context of that is that all of the people involved know that someone's going to come back and check whether they've done the intervention they've been trained in. Only 58% of practitioners used contingency management at any point over a 3-month period in Hengeles et al.'s trial in 2008. So despite knowing they were involved in an implementation trial, fewer than 2/3 of people given dedicated and specific training on the use of contingency management actually went on to use it. So again, that's a very low rate when you consider that it's likely to end up being lower once the implementation trial is over and once you know that you're not going to be asked again whether you're using it. So clearly there are problems in terms of the implementation of contingency management. And Becker and colleagues in 2018 also commented and identified some of the ideological objections that can extend to practitioners actually making judgments on an individual basis, so making a subjective determination as to whether or not they think it's appropriate or whether or not an individual service user is suitable to receive contingency management. And again, looking at that from a sort of moral and ideological perspective is really quite problematic, making a judgment about whether or not you think somebody's almost worth receiving a treatment that actually all of the evidence would suggest is a really effective intervention and likely to improve treatment outcomes. We ought not to be making those sorts of judgments in any clinical context. Myself and colleagues, and this is going to be in relation to a particular publication and review that I'll present in just a moment, have drawn parallels with a really interesting notion developed by Alex Stevens that he refers to as the moral sidestep in drug policy. This idea that in drug policy in the UK and certainly in other countries as well, there's a tendency to kind of take quite a conservative perspective on treatment, to politicise treatment in a way that we perhaps don't in other areas of health. And effectively to make these sorts of moral judgments about people who are worth or perhaps not worth being given support and treatment. And so this is a real problem, when we take something like contingency management, for it to be politicised and for it to be influenced in terms of its application by these sorts of issues. So just lastly want to come on to talk about some work that I've done with colleagues evaluating a particular type of contingency management scheme which is based on a point system, not dissimilar to something like a club card or a nectar card. I'm sure other forms of card are available. I'm not endorsing any particular one of them. Now, interestingly about the Capital Card, it was developed by an organisation called WDP, a substance misuse treatment organisation, so it wasn't developed by myself and my colleagues. We were rather involved in the evaluation of the scheme. But interestingly, it's a scheme that is, rather than being contingent on compliance, the points that are earned are contingent upon engagement with treatment. So whether or not that engagement is as you would want it to be, simply engaging in treatment is the thing that earns people points. We carried out an evaluation over a 2-year period pre and post implementation of the Capital Card because we were interested in what this did as an adjunct to treatment as usual. So this wasn't a standalone treatment or intervention, it was something that was implemented by the organisation to try to encourage improved engagement and therefore treatment outcomes. So our evaluation was essentially looking to see whether or not that had the anticipated positive impact. This is just a diagram taken from colleagues at WDP, which tries to illustrate the way in which the Capital Card works. So working through this kind of pathway, the idea is that everybody joining their treatment services are offered a Capital Card, and it's around about a 95% uptake and engagement rate, i.e. people who accept the card and use it is around about 95% in the services, certainly in the service that we evaluated in Hackney. And once you have the card, effectively for all of the different things that you could do through your treatment service, which can include things like vaccinations as well as other blood tests, attending group sessions, having any form of treatment, one-to-one therapy and so on and so forth, you earn points. And the number of points that you earn, and this was something that was co-developed and discussed with service users themselves, was that any of those things earns the same number of points. So there aren't different numbers of points that you earn. It's 10 points per intervention or treatment or engagement point throughout. As you earn these points, you can then use them to purchase various different things, which could be gym memberships, cinema tickets, access to training, and short courses through the library and that kind of thing. And there are various different rewards that you can access, which are based around the 5 ways to well-being. What's also interesting about the Capital Card as an aside, and we're looking at doing some further evaluation on this, is that the actual rewards themselves are donated by the local community and businesses and so on and so forth. I'll show you an example at the very end of people that attend Nando's and get a free lunch, although not entirely free. It's obviously based upon people engaging with treatment, which is hard work. But all of these rewards that people can use their points, redeem their points against, are things that are donated and therefore don't cost the treatment service money. Once people have completed treatment and left the service, they can continue to build up points for a further 6 months, and then for a further 6 months beyond that can spend the points that they have. And the idea is that this is something that you can see it's a form of contingency management. It's very expansive. It's not based upon one specific element of treatment, as often contingency management can be in the context of, say, people with opiate misuse problems. It can be based purely upon providing clear urine samples, and that's the only thing that will earn you any sort of reward. Whereas the approach here is much broader, that any form of treatment engagement or in relation to various aspects of treatment, including things like getting vaccinations and various other sorts of checkups, can earn you points, and those points can be spent in various different ways. So the methodology for the evaluation that we carried out, we started off looking across this 2-year period between the 1st of April 2016 up until 2 years later in 2018, and in the midpoint of that particular period the Capital Card was introduced in the Hackney Community Recovery Service, which WDP was running. This gave us access to 2,722 service user records over that period, and we were looking at data from both the Capital Card, so the points that people were accruing and the points that they were spending, and also something called the NDTMS database, which is the National Drug Treatment Monitoring Service, which is a database to which all drug and alcohol treatment services have to submit data, so that there is a central record looking at treatment outcomes nationally. So across this 2-year period, you'll see that we have here in the two middle columns the number of people in the no Capital Card and Capital Card condition, and you'll see that the total there adds up to less than the 2,722. So we have just over 1,500 participants or service users involved in this analysis in its entirety. The main reason for that was that although we were looking over a 2-year period, we had to exclude a number of people from the end point of the Capital Card period, i.e. people that didn't yet have a treatment outcome. So during that period up until the March 2018, if during that sort of early part of the month of March we had to somebody had joined the service but actually had many months ahead of them before we knew what the outcome of their treatment would be, because that was the cut-off point, those people were excluded from the analysis because we didn't know either way whether or not they had a positive or a negative treatment outcome. So it did give us a slightly different number of participants in each of the two conditions, but statistically speaking that's not a problem. It's just something we need to be aware of when looking at the overall figures here. So you can see, and you can look at this in a bit more detail in the slides, but you can see that we had more males than females, as you'd expect in a drug and alcohol treatment service. Is very often the case. The primary substance of use for the majority in both Capital Card and no Capital Card condition was alcohol, the primary substance of use, followed by opiates and then non-opiates. And also there seemed to be, although there were some significant differences in fact in the proportion of people who had housing issues, and in the main about 3/4 of people in both conditions had no housing problems, down to just under 10% in both condition of people who had no fixed abode, and the people in the middle were those that had housing problems, so either at risk of losing housing or were currently living with friends and that sort of thing. So it just gives you a bit of an idea about the type of service users that were involved in the evaluation. Here's just some basic information really about the engagement with the capital card scheme during this period. So a total of almost 40,000 points were earned on average. That was 92 points per user. Almost 8,000 individual interventions that this amounted to, a mean of 18 interventions or engagements, should I say, per service user. Interestingly, out of those almost 40,000 points that were earned, only 6,500 or just over 6,500 of them were actually spent, and that's something I'll come back to just at the end in terms of things and next steps that we've been considering. The top earn activities, the thing that the people were most likely to earn points for, were key working sessions, BBV appointments, and education sessions. So people turning up to some of the education sessions offered by the service. And the top spend activities, although there weren't nearly as many in relation to the points earned, it was using the capital card shop where people could buy vouchers and various other things, a bike service, and cooking courses. So you can see there's a range there of the different sorts of things people were doing. So we conducted an analysis, quite a straightforward analysis in a sense, to look at treatment outcomes primarily, and we were simply interested in whether or not there was any difference in treatment outcome, positive treatment outcome, for people who had the capital card compared to those people that didn't have the capital card. We use something called a hierarchical binary logistic regression. Sounds complicated, it's actually relatively straightforward. It's just looking at whether or not there are any statistically meaningful differences between two groups, in this case those that did and didn't have the capital card. And the reason it's called a binary logistic regression is that it's a binary outcome. You either had a positive treatment outcome or not. So you either successfully completed treatment or you did not complete treatment, which for the overwhelming majority of people meant that they dropped out of the treatment service earlier. We did in the model control for what was statistically significant group differences in the age of participants. I think they were slightly older in the capital card group than in the no capital card group. There was a slightly different proportion of gender distribution between the two, and also a slightly different proportion of people in terms of the various different primary substances. So that was statistically controlled for, to ensure that if we found any differences between the groups, that it wasn't due to the fact that there were just some differences between the type of service users involved in each condition. Interestingly and encouragingly, the overall model analysis was significant, and the main thing what this was telling us is that the capital card was associated with approximately a 1.5 times greater likelihood of a positive treatment outcome. So 1.5 times people were 1.5 times more likely to have a successful treatment outcome after the capital card was introduced compared to when people didn't have access to a capital card. So that was a really positive outcome, and what you would expect, given that, as I've just described, contingency management isn't exactly a new intervention, it's not exactly a new innovation. We know that contingency management works, but encouragingly for this particular implementation of the contingency management, this idea of using it to be based on engagement with treatment rather than compliance with particular aspects of treatment seems to have a positive effect. We're also interested because, as part of the NDTMS recording, drug treatment services are required to provide quality of life and psychological health change scores, or scores for different groups, both pre and post treatment and at various other points. Interestingly, what we found was during this period, and bearing in mind we were only looking at the treatment exit measures, we weren't looking subsequently at several months post treatment completion. What we found is that in both the capital card and no capital card groups, there was a positive improvement in both quality of life and psychological health scores. So both cohorts saw an improvement, but there wasn't any statistically significant difference between those two groups, so that you weren't more or less likely to have an improvement in either of those well-being measures if you had a capital card compared to if you didn't. And so that's interesting, and you may have expected that if there was an increase in the number of people with a positive treatment outcome, that it may have improved these things. But equally, these are also variables and factors that, if you've managed to successfully complete treatment, then it's likely you would expect to see these sorts of variables improve anyway. Whether or not having a capital card may have a sort of positive impact later down the line remains to be seen. And the other reason, and I want to come back to the point that I made with regards to the number of points that was spent, when I mentioned that just now, the reason I wanted to come back to it, particularly on this slide, is that clearly not very many points were being spent. So the positive impact of the capital card in terms of seemingly improving positive treatment outcome may not necessarily be due to the actual rewards and what they gave to the service users themselves, because actually more often than not people were just saving their points up, or at least not getting around to spending them during the period of time that we conducted our analysis. I've already mentioned as well that once people complete treatment, they have up to 12 months to spend the points that they have. Now we need to do some follow-on research to look at what people do spend their points on, indeed do they spend their points during that 12-month period. And of course it may well be that that sort of thing could lead to more positive improvements in these sorts of quality of life and psychological health scores. But the fact is at the moment we just don't actually know. As the final thing I wanted to share, and this was something that was really interesting from a service user, was some feedback given on the capital card for somebody who attended a Nando's session taking their friend. So I'll read this out because I think it's really quite encouraging, and I think acts as an interesting counterpoint to what I also mentioned earlier with regards to some of the moral objections that appear to exist in the minds of some people with regards to the appropriateness of using contingency management and rewarding people for engaging in treatment. So the person here says, I used to visit Nando's with my school friends. It was our regular weekly after school treat. We would always joke with each other and daydream about who would be first to get a Nando's black card. All through my drug usage, I found that I isolated and disconnected with my family and friends. Being invited here today for a free meal, sorry, not free, but paid for by my recovery earned points through Capital Card, is a huge treat. It's been nostalgic, esteem and confidence boosting, as well as a pat on the back from the cockerel from my hard work. Thank you. So I think that's a really encouraging kind of perspective on an intervention of this kind, which is designed in this particular case as fundamentally a form of contingency management, but also something that's been designed in a more innovative way, I think. And I'm not trying to sell the capital card here, I've no financial interest in it, but what really intrigues me about the approach that this organisation's taken is it's something that really is about embedding people back into the community and giving people access to rewards that aren't just cash, but giving them opportunities to do ordinary things, things that they may have felt excluded or unable to do as a consequence of some of the difficulties that they've had. So that's a positive note on which to end, despite some of the difficulties with contingency management being implemented. So what have we learned in this short session? We've discussed contingency management as a form of intervention that's based upon the basic principles of learning theory, and as I've said several times, it's not new. Contingency management has been around for a long while and it's been used in multiple different contexts outside of substance misuse, but it has a particularly strong evidence base in the substance misuse field for helping people to overcome addictions, both as actually a standalone intervention but also as an adjunct intervention which can improve the outcomes for people who are engaged in other forms of treatment. We looked at some of the evidence and outcomes for various different groups, and we also considered and discussed some of the barriers to the implementation of contingency management, which, given everything I'm saying about how positive it can be, it's interesting just how infrequently it appears to be used. We then worked through an example of a recent evaluation of a form of contingency management based upon the principles of contingency management, where people are rewarded for engagement in treatment, and saw that had a positive outcome. So hopefully that's been really useful and gives you some insight into some of the more practical applications of the really basic principles of learning theory that, despite actually being a pretty old theory as far as addiction science is concerned, can actually still have one of the biggest positive impacts.